the diseases of the gastrointestinal system. So this is part six, understanding the transmission, prevention, and control of common infection of gastrointestinal tract. So most of you already know me, so I will skip the introduction part. So learning objectives for today's class are first of all introduction, then this is my style of teaching. I always go with the basic definitions first, and by building up a rapport with the terminologies that are being used in my upcoming class, then we go ahead and start discussing the main topic. Then common infectious agents of gastrointestinal system, we will discuss some common infectious agents. Obviously not all of the infectious agents can be covered in a single class, but the most common ones will be covered in this class. Viral gastroenteritis, then Staphylococcus aureus induced food poisoning, Bacillus cereus, Clostridium botulinum. These are the bacteria which cause many of the infections. Uh, okay, now my screen is
Yes, I was.
on slideshow. So
Yes.
then E. coli induced GI infections, then Salmonella. I will cover only non-typhoidal infections, because if we go talk about typhoid fever or enteric fever, then it will deviate from our today's class, and we don't have this much time to cover all of the things, but we will cover most of the things. Then we will cover the shigellosis, which is basically Shigella, a bacteria which causes very severe form of dysentery. Then bacteria called Campylobacter and the infections related to the Campylobacter. Then Vibrio cholera, the most known of these bacteria, which caused many cholera outbreaks in many underdeveloped and developing countries of the world and caused so many deaths. Then giardiasis and amoebiasis, which are protozoal infections, not bacterial infections, but we will discuss them in the end as well. So, bacteria, viruses, or fungi are microscopic single cell organisms that can live inside or outside our body. Many microorganisms play a vital role in human health. We live on our skin and in our bodies, playing a role, for example, in digesting food. However, some microorganisms can also cause infectious diseases. GI tract infections are very common. Diarrhea is the most common cause of death in developing countries. 2.5 million deaths per year. Diarrheal disease is the third leading cause of death in children under 5 years old, and is responsible for killing nearly half a million children every year. Over 211 million cases of diarrhea occur alone in the United States every year. Pathogens causing diarrhea can be transmitted to humans in three basic ways, either through food, through water, or through person to person. Many of these infections are self limiting and do not require treatment. Some can spread to other sites in the body and require treatment to prevent further damage. The trick is in knowing when to treat and how to treat patients. There are enormous number of microbes that cause disease in the intestines. Bacteria such as E. coli, Salmonella, Shigella, Campylobacter, Clostridium, etc. Viruses such as Norwalk, rotavirus, and parasites such as Giardia and Amoeba and Ascaris can all cause diseases in the intestines. Most of the time, infections of the intestine result in diarrhea or dysentery, nausea, vomiting, and abdominal cramping. If the infection is in the small intestine, symptoms include watery diarrhea or vomiting. Infections in the large intestine usually result in dysentery in a small fecal volume, but it is mixed with mucus and many times blood as well. So, if the infection is in the small intestine or if our small gut is affected, we mostly get watery diarrhea, and there is also vomiting as well. But if the infection is in the large intestine, usually results in dysentery. The fecal volume is small, but it's filled with mucus and many of the time blood as well. Basic definitions. So, diarrhea. What is diarrhea? Diarrhea in adults is defined as passing three or more loose, watery stools per day, or passing stools more frequently than is normal for the individual. What is vomiting? Vomiting, also known as emesis, is the forceful involuntary ejection of some or the stomach's contents through the esophagus and out of the mouth. Enterotoxin. An enterotoxin is a poisonous substance produced by certain bacteria that affects the digestive system, causing symptoms like vomiting, diarrhea, and cramps. These toxins are often released by bacteria in food or water, leading to foodborne illnesses such as staphylococcal food poisoning. So basically, an enterotoxin is a substance that is produced by bacteria, and this uh, toxic substance affects our digestive system. And if we intake that toxic substance, our digestive systems become sick, and we start vomiting and have diarrhea, or we start having cramps, etc. What is a parasite? A parasite is an organism that lives on or in a host organism, deriving nutrients from it at the host's expense. The relationship is one sided, as the host is harmed and it does not benefit from the organism. Parasitic organism. Parasites can be single-celled organisms like protozoa or multicellular organisms such as worms or external creatures like fleas and ticks and lices. Basic definitions continued. So, gastroenteritis. Gastroenteritis is the inflammation of the stomach and intestines, causing symptoms like nausea, vomiting, diarrhea, and abdominal cramps. It is often caused by viral or bacterial infection, but can also result from parasites such as protozoal infections as well. And what is dehydration? Dehydration is a condition where the body loses more fluid than it takes in, resulting in a fluid deficit that prevents it from functioning normally. It can be caused by not drinking enough fluids, excessive fluid loss from sweating, vomiting, or diarrhea, or medical conditions. So, now we come to our class, understanding the common infections of gastrointestinal tract. So we'll discuss the most common GIT infections and how to treat them or manage them in this section. So these are the commonest infectious agents of the gastrointestinal system which I will discuss in today's class. So in bacteria, the number one common infection causing thing is Staphylococcus aureus, Bacillus cereus, Clostridium botulinum, E. coli, Salmonella species, Shigella species, Campylobacter species, and Vibrio cholera. So basically, these are the bacteria which cause the bacterial common infections, and then there are some viruses as well, such as rotavirus, Norvac virus, adenovirus, etc. They cause viral gastroenteritis all around the world. And although bacterial infections are more severe, viral infections are most common. So, 70% of the gastroenteritis that occurs in populations is not due to bacteria, but it is due to viruses and parasites, Giardia lamblia and Entamoeba histolytica, etc. These are the parasites which cause common infections of the gastrointestinal system. So we will start with the viruses, then we will go on to discuss the bacteria, and then we will discuss the parasites as well. Viral gastroenteritis. So viral gastroenteritis is leading cause, nearly 70% causes of food poisoning or AGE. AGE means acute gastroenteritis. And what is acute gastroenteritis? We've already discussed that in definitions. So viral gastroenteritis is the leading cause of food poisoning or AGE in all around the world. The number one cause is Norvac. It is common year round. This is the leading cause of viral gastroenteritis in the United States as well. Then there is rotavirus. This is the leading cause of gastroenteritis in children, and it has more outbreaks in winter than in summer. It is the leading cause of gastroenteritis in children, but can also be found in adults. The rotavirus may cause severe dehydration as well. Some other viruses as well, such as enterovirus, adenoviruses, etc., often occur in epidemic fashion in closed environments, example given cruise ships, schools. Viral cultures rarely indicated. ELISA and PCR assays can be done if needed. Fecal leukocytes are absent. Self-limiting, although hospitalization and rehydration may be needed in severe cases. So, now we go on towards the bacteria. So the number one bacteria is Staphylococcus aureus. Staphylococcus aureus causes food poisoning a lot, and the cause of Staphylococcus aureus induced food poisoning is from foods left at room temperature, particularly milk, salads, cream products, and some meat and fish as well. But milk and salads, if they get rotten, they are more likely to contain Staphylococcus aureus. So there is nausea and then vomiting preceding diarrhea. So first of all, you start having vomiting episodes and then it precedes the diarrhea. Fever is there, abdominal cramps are there. So yeah, it causes fever, it causes abdominal cramps, and the nausea is followed by vomiting, and vomiting is followed by a delay of 6 to 8 hours by diarrhea. Complete recovery time in healthy individuals is usually 24 hours. History of similar illness in others eating same food as well. So most of the time, there is a group of friends, a group of people who are affected who took the same food. Fecal leukocytes are usually absent. Lab studies to distinguish between this and viral causes do not change management and are usually not done. Management is with fluids and electrolyte maintenance. And IV antibiotics can be given only if the symptoms get severe. So basically, most of the time, the management is supportive. You do not give IV antibiotics. You just give anti-emetic medication, IV fluids, and if the vomiting stops, then you can shift to oral fluids as well. And IV fluids are also initiated if the patient's blood pressure is around 100 or less than 100. So if the blood pressure of the patient starts to drop, then you start IV fluids as well. So, what is the mechanism of Staphylococcus enterotoxins? So, the Staphylococcus enterotoxins disturb the activity in the large intestine. So, what do? They do not let the water to get reabsorbed in the large intestine. So what happens? The stool contains too much of water, and when the stool contains too much of water, then what happens? That there is increased gut motility and increased frequency of passing stools. So water can be reabsorbed in the large intestine, and when water can be reabsorbed, there is episodic diarrhea, and the patient has to go to the bathroom again and again. When Bacillus cereus, it is a gram-positive, spore-forming aerobic rod, not bacteria, but spores survive cooking, germinate when food is improperly stored. It produces two distinct toxins and two clinical syndromes related to the toxins produced by this bacteria. Number one is emetic or vomiting type of toxin. The toxin is cereulide. It is preformed and heat stable. And food classically involved in these toxins are fried rice, pasta, and starchy foods. Onset is rapid, 1 to 6 hours after ingestion. Symptoms are nausea, vomiting, plus minus abdominal cramps. There is no diarrhea, it's just vomiting. And pathophysiology is same. If there is canned stored food and there are spores which germinated inside that canned food and converted into bacteria, and then that bacteria produces the toxin cereulite, and when we take that food, the cereulite goes inside our stomach or intestine, and it starts to create the problem for us, and we start having vomiting episodes. Then there is another toxin, which is diarrheal type of toxin. It is heat labile enterotoxin, and it is produced in gut. And the foods which contain bacteria are meat dishes, sauces, soups, and vegetables. Onset is slower, 8 to 6 hours. I apologize for a bit having a bit weariness. It's just because of my long calls. I'm having very long calls these days due to the overburden at our hospital, due to some law and order situation going on in our region. Okay, so symptoms: watery diarrhea, abdominal pain, and cramps. And pathophysiology is bacterial multiplication in intestine, so the toxin release occurs in the intestine. So what happens that you eat something which contains live bacteria, and these live bacteria starts replicating inside your intestines, and then they produce this heat labile enterotoxin. Heat labile means it is not heat stable. It is not heat stable, so if you put heat into it, it will change its nature, and it will not be toxic anymore. So this toxin causes diarrhea in patients, and cereulite toxin causes emetic or vomiting episodes. So diagnosis is mostly clinical based on typical onset plus food exposure. Lab confirmation is rarely needed. Culture from food and stool and detection of cereulite toxin in the stools can be done if you really need a lab diagnosis. Management, it is usually self-limiting. Supportive care is needed. Oral or IV hydration, antiemetics or antidiarrheals can be given if needed. Antibiotics usually not recommended as no benefit. Illness is due to toxin and not bacteria itself. So most of the time, our body copes and destroys the bacteria within 1 or 2 days. So basically, supportive medication and taking light food, taking yogurt, taking water, these things help, and antiemetic medication as well, so that the vomiting stops and you start taking orally instead of IV fluids again and again. Prevention is proper food handling and storage. Cook thoroughly. No, you will repeatedly hear this word of cook thoroughly, cook thoroughly, cook thoroughly, because most of the time the problem is that the food that we reheat again and again, it is not cooked properly. So you should cook thoroughly. Avoid keeping cooked foods at room temperature. Rapid cooling of rice and starchy foods should be avoided. Should be done. Should be done. If you reheat something, then there should be rapid cooling of rice and starchy foods in order to let this bacteria not grow. And refrigerate below 4 degrees Celsius within 2 hours, and reheat foods adequately before serving. If you are using a refrigerated food, then you should uh, reheat it adequately and properly, so that all of the live bacteria at least get destroyed. Then there is another bacteria called Clostridium botulinum, and it causes a very, very devastating illness called botulism. It is a gram-positive anaerobic spore-forming rod. Bacillus means rod. We already know this terminology of bacillus from our previous class, where we discussed in details what is a coccus, what is a bacillus, etc. It produces botulinum neurotoxin BONT, one of the most potent toxins known. Spores survive boiling, germinate in low oxygen, improperly processed foods. Sources are home canned foods, pickles, fermented fish, herb infused oils, honey as well. So it is a very dangerous bacteria because it can cause a very devastating illness. Pathophysiology is ingestion of preformed neurotoxin, that is botulinum neurotoxin, and it is absorbed from gut, blocks acetylcholine release at neuromuscular junction, and when acetylcholine release is stopped, then the problems with the muscles start to happen. The clinical features are onset is 12 to 36 hours and range is 6 hours to 8 days. The GI symptoms are nausea, vomiting, and abdominal cramps. Neurological symptoms are classic descending pattern of uh, paralysis. So basically, the descending paralysis happens due to botulism. So first of all, your eyes are affected. You start having diplopia or blurred vision. Then there is ptosis. Ptosis means drooping of the eyelids. If I try to open my eyes and I'm unable to open them, this is ptosis. I have to look at this chin up posture in order to look forward. If I can't move my eyes upward like that, the upper eyelid, then it is ptosis. And ptosis happens because there is descending paralysis of the muscles in this disease. Then this R3 and dysphagia. So basically, patient cannot speak properly, patient cannot engulf anything or take a bolus of food properly. Symmetric descending paralysis is there, and the problem with this symmetric descending paralysis is that if you do not treat it, if you do not hospitalize and ventilate the patient, the respiratory failure is going to come, and all of the respiratory muscles are also paralyzed. And there is no fever, patient remain alert, and this ordeal is very painful for the patient. So diagnosis is mostly clinical, history of home cane wounds plus descending paralysis. But if you really want to confirm, then there is a confirmatory test, which is the toxin, that neurotoxin can be detected in serum as well. And culture of Clostridium botulinum from stool or food can also be done. Management, as if the descending paralysis is there, it is a medical emergency. So first of all, what you do, botulinum antitoxin is given. It stops progression of the disease but does not reverse established paralysis. So you should know that if you are suspecting descending paralysis, then you should given the botulinum antitoxin as soon as possible, because it stops the progression of the disease and respiratory system is not involved. But if any of the muscle groups are already affected, it does not reverse the established paralysis. Then there is supportive care, airway for us, respiratory support is also given. NG feeding is initiated if the patient cannot swallow properly, and if there is any open wound, then wound debridement plus antibiotic for only for wound botulism as well. Avoid antibiotics in pure food-borne botulism because it may worsen the toxin release. Prevention is properly sterilize and pressure canned foods. Boil home canned foods for 10 minutes before eating. So 10 minutes boiling is a rule. If you are having to eat a boil home canned food, then you should boil it for 10 minutes before eating. And you do not give honey to infants less than 1 year of age because there is a risk of Clostridium botulinum present in honey. And if there is this bacteria in honey, it can cause descending paralysis in the infants as well. Then there is another bacteria called E. coli. So E. coli is enterotoxigenic or enteropathogenic or enteroaggregative. So ETAC is heat labile. It produces heat labile and heat stable toxins, and it causes secretory diarrhea. EPEC or enteropathogenic E. coli. It causes malabsorption type of diarrhea. And then there is EHEC or STEC Shiga toxin. It causes endothelial injury of the gut, and it may also cause hemolytic uremic syndrome. Now, the um, normal incubation period of ETEC or EPEC is 1 to 3 days, and in enterohemorrhagic type, usually it's 3 to 4 days. Now, the problem is E. coli also occurs from uncooked meat and raw milk, etc. but and fruits and vegetables can also contain it, so you also wash the fruits and vegetables before use, and you always boil the milk before use, and you also cook the food properly if you're taking meat. So watery diarrhea is present in toxigenic and in enterohemorrhagic strains. Bloody diarrhea is there, and there are severe cramps as well. And in enteropathogenic, prolonged watery diarrhea is there. So basically, there are strains of E. coli. So the most devastating or most dreadful or more dreaded is EHEC, which is enterohemorrhagic E. coli, hemorrhagenic. Then what do you do? What is the management? You rehydrate, you rehydrate, you rehydrate, because most of the deaths just occur because of dehydration due to vomiting and diarrhea. Avoid antibiotics and antidiarrheals in EHEC because it increases the risk of hemolytic uremic syndrome. Hemolytic uremic syndrome is basically the development of the disease of renal failure and hemolysis as well. And what is the prevention? To prevent E. coli infection, focus on food safety by cooking meat thoroughly, washing hands frequently, and drinking safe water. Washing fruits and vegetables and avoiding unpasteurized products is very, very important as well. Then salmonella. We will only discuss the non-typhoidal infection caused due to salmonella. So, if you look at the life cycle or the sources of salmonella, it is present in poultry, eggs, milk, reptiles, birds, etc. So, these are the natural sources of the salmonella bacteria. So, what happens is that all of these sources they already contain the salmonella bacteria, and they are not damaging for the hands, they are not damaging for the birds, but what do? They can become damaging for human beings as well. So bacteremia is there, and bacteremia risk in infants is more, and elderly and immunocompromised. The incubation period of this bacteria is 6 to 7 hours. So the clinical features are the same, almost always fever, abdominal cramps, nausea, and mostly the diarrhea is watery. Sometimes bloody diarrhea can also be there, but mostly it's watery. The diagnosis is through stool culture or PCR, and management is almost the same. It is supportive, and fluids and electrolytes are given. Avoid antibiotics in mild cases, but if the case is severe, if the patient is showing fever, if the patient is becoming toxic, then you do give antibiotics as well. Treat severe cases with ceftriaxone, azithromycin, or any fluoroquinolone such as levofloxacin or gatifloxacin, etc. And then the next bacteria is Shigella. It is a very, very dangerous bacteria because only 10 or 20 bacteria, if we intake that bacteria, they are enough to cause the full-blown disease of shigellosis. Just 10 or 20 bacteria is a very, very small number in the realm of bacteria, because most of the time, if we take a single bite, we are taking millions of bacteria inside our body. So it's just a very small piece of bite or very small piece of infected source you need to take in order to get infected by this dangerous bacteria. Transmission is through fecal oral route, contaminated food or water, or person to person as well. Pathogenesis, it invades colonic mucosa, especially distal colon and rectum, and it escapes phagosome, which is why it replicates intracellularly, and it spreads from one epithelial cell to another epithelial cell, causing epithelial death and ulceration in the intestines of the patient. So, Shigella dysentery type 1 produces Shiga toxin, and it inhibits 605 ribosomal subunit, and cell death can cause hemolytic uremic syndrome as well. So, Shigella dysentery is very dangerous. There are some other forms of Shigella bacteria as well, which also cause infection, but their infections are relatively less severe. So I did not bother to discuss all of the types as well. Then epidemiology and risk groups are common as is it is common in children less than 5 years of age. Outbreaks in daycare, schools, and crowded settings are common. High prevalence in areas with poor sanitation and contaminated water. Clinical features are rapid onset, that is 1 to 3 days. High fever, chills, severe abdominal cramps are there. Frequent small volume stools with blood, mucus, and pus in isthmus and urgency is there. Complications of this infection can be dehydration, and seizures can also start to occur, especially in children. Toxic megacolon and hemolytic uremic syndrome can also occur in this if the patient is infected with this bacteria, then the patient can suffer from toxic megacolon or hemolytic uremic syndrome, in which there is renal failure as well hemolysis of the red blood cells as well. So the patient gets anemic very early, and the patient's renal function profile also gets destroyed. Then the diagnosis is of stool culture. It is a gold standard. If you are suspecting Shigella, then you need to perform stool culture. Stool PCR panels are also done, which are rapid and sensitive for this bacteria. Stool microscopy can show leukocytes and RBCs in blood cultures if systemic toxicity or young infants are affected. Management is through rehydration, then antibiotics shorten illness and transmission. So first line is azithromycin or ceftriaxone. Alternative, depending upon resistance, such as ciprofloxacin and trimethoprim sulfamethoxazole. Avoid anti-motility drugs, because if you are having any kind of bloody diarrhea, then you need to evacuate your gut instead of giving anti-motility drugs. Anti-motility drugs basically stop the gut movement and stop the diarrhea, but it worsens the shock of the patient due to Shiga toxin accumulation inside the gastrointestinal system. Manage complications such as electrolyte imbalance and seizures promptly in this case. So our next bacteria, which causes too much of the infections in our populations, is Campylobacter jejuni. Campylobacter is basically a bacteria which causes the infections of the jejunum or small intestine. So it's curved motile gram-negative rod. It is common in poultry and unpasteurized milk. In which small and large intestine inflammatory diarrhea, incubation is 2 to 5 days, and associated with this bacteria is Guillain-Barré syndrome, which is ascending paralysis. So in Guillain-Barré syndrome, what happens that first of all, our feet are become paralyzed. We cannot move our feet, and then our leg, and then our knee joints, and then our thigh. And this paralysis, if not treated promptly, can reach up to the respiratory system, and our patient may die. Prevention is through various measures such as cook poultry properly, avoid unpasteurized milk, prevent cross contamination in kitchens, and safe water and hygiene during food preparation should be uh, taken care of. So the clinical features are almost the same. There is diarrhea, there is severe abdominal pain, there is sometimes fever and malaise as well. So the diagnosis can be done on clinical grounds, but if you really need to test it, stool PCR or culture are done, and management is via oral and IV hydration. And if oral and IV hydration does not improve the symptoms of the patient, then you give azithromycin as the first line and first class of drug. Avoid anti-motility drugs in dysenteric illnesses as well. So you do not give anti-motility drugs because you need to evacuate your gut as fast as possible and replenish your IV fluids. Then the next devastating bacteria, which has caused too many epidemics in various regions of the world, is Vibrio cholera. It's a curved, motile, gram-negative rod, and its reservoir is contaminated water with this bacteria, and it spreads via fecal oral route. So, for example, if we are taking a water reservoir, and many of the people who are using that reservoir or passing stool, etc., then definitely it can spread through fecal oral route. The pathogenesis for this bacteria is it colonizes small intestine via TCP pili and produces cholera toxin, which causes increase in cyclic monophosphate, adenosine monophosphate. And if there is cyclic increase in cyclic adenosine monophosphate, then there is massive chloride and water secretion into the intestines, and with massive chloride and water secretions, there is a lot of diarrhea, and it causes profuse watery diarrhea without mucosal invasion. So it causes profuse secretory watery diarrhea, and sometimes the microbiologists or the medical specialists also call it rice water stools, because the patient is just passing watery stools and large amount of stools, and if these two the IV fluids are not replaced early, the patients die within 12 hours. Prevention is safe water and sanitation, hand hygiene, cook seafood thoroughly, and oral cholera vaccine in endemic areas are also there. What are the clinical features? So sudden onset of rice water diarrhea, and it is very sudden and very severe. And vomiting and muscle cramps can also be there. There is rapid dehydration of the patient because patient is passing too much of the fluid, losing too much of the fluid in the name of diarrhea. So there is rapid dehydration with the resulting tachycardia, hypotension, and shock. The incubation is hours to 5 days. So if there might be some cases where bacteria has not harmed the patient for 5 days, and after 5 days the infection occurs, and there are cases in which just a few hours are needed by the bacteria to start the infection. So the diagnosis is primarily clinical, but stool cultures can also be done for Vibrio cholera culture and sensitivity testing. Rapid antigen tests or PCR can also be performed in order to understand what bacteria is causing these severe symptoms. Antibiotics can be given, such as azithromycin or doxycycline, and zinc for children is given because zinc deficiency is very devastating after severe cholera illness. And continue feeding and breastfeeding of the patient if the patient is feeding from mother or if the mother is breastfeeding them. And complications are severe dehydration, renal failure, electrolyte imbalance, and the patient can die as well. So our second last organism of today's class is a protozoal infection causing protozoan called Giardia labelia. It is not a bacteria, it is a protozoan, and it causes a protozoal infection, but it is also very common all around the world. So I had to include this in common gastrointestinal infections as well. Flagellated protozoan exists as cysts, which are infected, and trophozoites, which are other form other than cyst. The transmission is also through fecal oral route or contaminated water or food or person to person. So the transmission is for all of these bacteria and all of these organisms almost same. So high-risk groups are travelers, hikers, and daycare centers. The pathogenesis is ingestion of cysts, which exist in small intestine. Trophozoites attach to mucosa, and this mucosal attachment by the trophozoites causes malabsorption, and fat is unable to get digested, and there are brush butter enzymes which are also damaged as well. It impairs fat absorption, and steatorrhea occurs, and steatorrhea means passing fat in the stool. So impairs fat absorption. Giardia impairs the fat absorption. There is no invasion of tissues as well, but it is very dangerous because it causes most common cause, it is one of the most common cause of chronic diarrhea as well, because the patient is not that much sick or patient is not that much toxic, so they'll live on for 3 or 4 weeks with this diarrhea, and they don't know that they are infected, and they keep living on with this diarrhea for many weeks to come. And the prevention is through boiling or filtering drinking water. And chlorine does not kill the cyst, so chlorine is useless. Either you use small filters, micro filters, or you just boil the drinking water. And hand hygiene and sanitation are also very important. And seafood water precautions while traveling are very important. You do not just take seafood from everywhere. You first make understand it, that whether the seafood is healthy or not. No, this is the life cycle of giardia. You can take all of the uh, infected items, and these infected items contain infected cysts, which are directly digested. Then these cysts exist themselves, and trophocytes are produced, which trophocytes attach and multiply in the external epithelium, causing destruction and illness. The trophocytes migrate toward the colon and undergo infestation again, a process that transforms back into the cyst form. And this cyst is then evacuated in the gut, in the stools, and then these stools reach our food chain, and then the cycle goes on. So the diagnosis is not through PCR or something else, but you do ELISA or stool ova and parasites as well. The stool antigen test are most sensitive. PCR panels can be done as well. The stool ova and parasite and ELISA testing is more common these days. And the management is through metronidazole or trinidazole. Alternatives are nitazoxanide, but basically patient needs nutritional support due to prolonged diarrhea, and patient also needs rehydration as well. Treat household contacts if symptomatic as well. And the last uh, infectious agent for our today's class is amoeba. And we already know from our childhood school time classes that what is an amoeba. It is ant amoeba histolytica. It forms infective cysts and invasive trophozoites as well. Its transmission is also through fecal-oral route. It is common for all of these bacteria and protozoans to use fecal-oral route, and its pathogenesis is just like the pathogenesis of giardia. We ingest the cysts, and these cysts exist themselves in large intestine, and trophocytes invade colonic mucosa. There are ulcers, and sometimes dysentery is there, amoebic dysentery, which causes bloody diarrhea in individuals. And it can spread via bloodstream, such as liver abscess, most common extraintestinal sign. The prevention is through safe drinking water, sanitation, hand washing, proper food handling, avoid raw, unpeeled food in endemic areas, and treat carriers to prevent transmission. So this is basically the life cycle. First of all, we ingest a mature cyst. Mature cyst causes excistation, and then excistation results in trophozoite formation. These trophozoites migrate to the large intestine. Then trophozoites go into when they go into the large intestine, they invade the intestinal mucosa and cause ulcers there. And when there is intestinal mucosa affected, there are chances of invasive infection as well through the bloodstream, infecting sites such as the liver, brain, and lungs as well. And after these cysts are spreading all around through the body, these cysts usually start exiting the host in stool, and when they start exiting the host in stool, then there are chances that this cyst will be used again, eaten again by some other individual. So the management is tissue mibicide is given for invasion, such as metronidazole or trinidazole, and with a luminal agent to eradicate cysts such as paromomycin or doloxonide furoate. So drain liver abscess if there is large liver abscess due to amoeba, and if their left log is involved, or if there is risk of fracture. Rehydrate, manage anemia, and nutritional support as well. Have a nice day, and thank you. So this was our class for the commonest infectious agents of our gut. I hope all of you understood. I try to make it and keep it as simple as possible for better understanding of all of you. So I think it was not that much complex. I used the common language to make you understand as well. So, questions, please.
That's very, very awesome, Dr. Omer Faroukan. You've done a superb job for the family of Atlantic International University. And on behalf of that group, I want to express our deep gratitude for your good job. Ladies and gentlemen, what we just received is a huge array of information, both theoretical and in terms of routine hands-on about how to understand the transmission, the prevention, and the control of common infections in our gastrointestinal system. And I do
Yeah.
hope you thoroughly assimilated everything and are getting ready to take appropriate steps to implement what you learned from our wonderful subject matter expert, Dr. Omer Faroukan. We are
Thank you,
getting into
sir.
the questions at this time, beginning with Ismail Adebola. Go ahead, brother. We all ears.
Go ahead.
Yeah, good morning, sirs. Good
Good
morning.
morning.
Yes, sir. Good
Good
morning,
night
everyone.
from Pakistan.
Thank you, sir. Thank you for the presentation. Yeah,
Uh,
this is my question,
yeah,
sir.
you're welcome.